this is Dr. David Brady, and welcome to the Fibro-Fix Summit. We're here with one of our esteemed experts, a good friend of mine, and a very respected colleague, and one of the most knowledgeable people I know in this topic of fibromyalgia, and that's Dr. Michael Schneider. And Dr. Schneider graduated from the Palmer College of Chiropractic in 1982, and then went on to obtain his PhD in rehabilitation science from the University of Pittsburgh in 2008. He's currently an associate professor at the University of Pittsburgh in the School of Health and Rehabilitative Sciences. He's been seeing patients as a chiropractor for over 30 years and specialized in the treatment of muscular and myofascial pain, including patients that came in with a diagnosis or a label of fibromyalgia. At the University of Pittsburgh, he sees patients at the Center for Integrative Medicine, where he collaborates with other integrative practitioners and other approaches, including naturopathic medicine, massage therapy, yoga, mindfulness meditation, Tai Chi, and others to combine a comprehensive treatment plan for fibromyalgia patients. Dr. Schneider has published and lectured with me on many occasions. We have many co-authored papers together in the peer-reviewed medical journals, in medical textbooks, and lay publications as well. And there's, like I said up front, there's very few people, if any, who I respect their knowledge in this topic more than Dr. Schneider. So thanks for being with me, Mike.
Okay, great. My pleasure.
Well, you know, we've bantered some of these topics around for upwards of 25 years, I don't know, at this point. And sometimes I think we felt like we were howling into the wind. And I think both of us had a similar epiphany, you know, way back in our careers with this thing we call fibromyalgia. And correct me if I'm wrong, if I'm speaking for you in a way that's not accurate, but I know that I got to the point very soon after my training was completed, at least my initial training as a chiropractic physician. You had much more experience than me by that point, but I realized that I was not prepared for treating patients with fibromyalgia, and that I knew little about it. I just didn't really understand it. And once I started learning more about it, partly thanks to you, I started realizing that nobody else knew much about it either. The healthcare practitioners were confused, the patients were confused, the healthcare practitioners were confusing the patients even more. So we set out on a journey to try to educate healthcare providers more about this disorder. And now this latest, and we did that for many, many years, and this latest project with the summit and the upcoming book, The Fibro-Fix, is really about taking this message directly to the people who have been told they have fibromyalgia, who may have it, who may not have it. So just to start, sort of from 30,000 feet, you know, your perspective on this thing we call fibromyalgia and how you've had to deal with it in your career. Any just opening thoughts about it for the listeners?
Yeah, sure. That was a nice little summary. I mean, for me, as you started talking about my little bio there, I was always interested as a chiropractor in people who had pain.
Right.
And since I focused on soft tissue pain in my practice, I did a lot of trigger point therapy.
Right.
So I remember 1990 when the first article came out about fibromyalgia, very first article, 1990, my first impression was, oh, these researchers, they've just got it wrong. They're saying tender points, that's trigger points.
Right.
What's the big deal? This is all the same thing. And then after a couple of years, I started realizing, oh, I see what they're talking about. This, what you and I call a classic fibromyalgia patient,
right?
That's not trigger points. That's something else.
Right.
And I didn't know what that was at that time. But then as the years went by, I started seeing there were patients that have truly muscular or joint pain, and then there are people who don't and fit the sort of classic profile. And then there are people that are just completely mislabeled in the first place, don't have either one.
Right.
And that was sort of the beginning of it. And I think you and I then started going down that road, trying to sort people out into these different categories.
Right, because, you know, the term fibromyalgia, right, just means pain in the fibrous tissues, you know, the softer tissues, not the hard tissues like bones and joints, but the muscles, tendons, ligaments, fascia. But it's very nebulous, right? It just means pain there. But when we started really digging into the literature and what the rheumatologists and all were talking about, was really that the pain was not in those soft tissues. The pain was just perceived in those soft tissues in this classic model of fibromyalgia, which is really this centralized pain processing disorder where there's things that are going wrong in how we process information coming into the brain itself, that the problem is not in the muscles or in those soft tissues. It's just felt there. So that was what we called classic fibromyalgia, that all the classic presentations of what the literature was talking about of these central sensitization disorders. So it had the depression and the anxiety and the unrefreshed sleep and the IBS and all those other things, where what we were seeing as chiropractors often, and we were successfully treating, are these patients that had a lot of pain, but they really actually had problems in the muscles out in those tissues, and they had these things we called trigger points, and we treated them with various ways and they got better. But then there was these other patients who seemed to be complaining of pain all over, but when you go and examine them and touch them and palpate them, they didn't have those trigger points and they didn't respond to the kind of treatments that we were used to giving. So that was where we decided, hey, we need to start really understanding this and we need to start writing about this. And I think initially our intent was to try to educate our fellow chiropractors at the time, but then we got more ambitious than that somewhere along the line, I think.
That's true. And, make a good point there that one of the things I learned early on was with these classic fibromyalgia patients, they hurt everywhere.
Right.
And that there was a real hypersensitivity that we didn't see with the trigger point type of patient, that it wasn't a localized regional sort of pain. They literally hurt all over their body.
Right.
And then as chiropractors, being a little bit more holistically oriented, we started realizing they weren't just sensitive to physical touch, they were sensitive to sounds. They had multiple chemical sensitivities, multiple food sensitivities, and it started leading towards this idea that maybe their central nervous system is just sensitized overall.
Right. And then that's what the literature started uncovering as well, that they had sort of irritable everything, right? And it goes with irritable bowel, irritable bladder, all this sort of what they call hypervigilance, right? Their nervous system is in this state of emergency all the time. Like they're always waiting for the next shoe to drop, right? That the next bad thing to come along. So they're primed in a way to expect a catastrophic type of event, if you will. But instead of being in that mode temporarily when there is a legitimate threat or a stressor, their nervous system has seemed to have been somehow get stuck in this pattern perpetually. Do you think that's an accurate way to describe that?
Yeah, and you're right. There's a whole emerging area of literature now showing that these patients, that what we call the classic fibromyalgia patient, that they tend to have irritable everything.
Right.
And the way I describe it to patients is it's like, the volume's been turned up on everything. So they're still having the same input. Like we're trying to get the volume here on our
right.
mic set. So their volume is set way, way up. So even the slightest little whisper in their brain becomes like you're shouting.
Right.
And that, to me, that's a good analogy of this. And whether that input's coming from the skin or muscles, or input's coming from their stomach, or that input's coming from other parts of their body, everything is ramped up.
Right, right. And that is interesting how that correlates with this issue of a lot of these patients who go on to develop fibromyalgia in adulthood. They're generally females, not exclusively, but the large preponderance of them are. And many of them in their histories, and I never really realized this until I really paid attention to it and did very good histories on these patients, that they have histories of sort of previous stress, trauma, even abuse. A lot of times they were brought up in a household with maybe an abusive, yelling, alcoholic father or something, or they got the mother was being abused by the father, or they witnessed something horrific, or there was something going on that made them feel fundamentally threatened or unsafe while they were young, while their nervous system was developing, learning how to cope with the world, and in sort of what we would call this neuroplastic state. And maybe they sort of took on this pattern, if you will, of looking at their world in a way that they may not have if they were not in that kind of environment when they were young. And what do you think about that theory, that previous trauma imprinting, sort of the body remembers the pain, the trauma, and maybe even the abuse itself?
Yeah, well, Now, since you mentioned this, there's actually quite a bit of literature in this area.
Right.
And we know for a fact that well, again, what we call the classic fibromyalgia patient, that there's much, much higher prevalence of physical, sexual, verbal abuse. This is pretty much becoming an emerging fact. What the interesting part is that some patients are subjected to this abuse and they don't develop these symptoms, which has led now to the idea that maybe this is partly a genetic issue, that some people are genetically sort of predisposed, if you will, to potentially develop fibromyalgia. And if they don't, or essential sensitization disorder, if they're not subjected to the abuse in their lifetime, they have the genetic predisposition, it's never expressed. Right? So the genotype does not become a phenotype, if you will, in medical terms.
Right, and I discussed that in the book and actually show some of the literature there that the higher prevalence of fibromyalgia, classic fibromyalgia, running in families, there is clustering that's passed on through, a family sort of genetics, but it has to be paired up with the right environment, right? The right environmental circumstances, and that's how most things work. There are some things that are really hardwired genetically, but most things are, you have a higher you have a higher likelihood of developing that if all of the things line up.
Sure. And we know just without even going to fibromyalgia literature, we can talk about, it's pretty well known that you have a family of 5 people, 1 or 2 of those family members might be very sensitive kind of people, and 1 or 2 may not be. And those sort of sensitive type people are ones that tend to develop fibromyalgia type symptoms when they're exposed to multiple prolonged stress. And that's what we're talking about here, not just a single incident typically. It's typically, it could be a low level of stress over a long period of time, or it could be one really, really terrible thing that happened.
Right. And it seems to be that even people who maybe sort of harbor this sensitivity or this susceptibility, if they have an event like that as an adult, let's say they're abused or they, have some sort of traumatic scenario, they seem less likely to go on to develop things like fibromyalgia and IBS than if they were exposed over long periods of time to significant stressors or abuse when they were young and growing and their nervous system was sort of learning. Do you put much credence in that?
Oh, for sure. Yeah, I mean, again, it's not just that I put credence in it. There's a lot of evidence to show that the younger, the more malleable your nervous system is when trauma occurs, the more ingrained it becomes into your nervous system, the harder it is to change that later on.
And it's interesting that some of the same neurotransmitter abnormalities, the tendency toward lower serotonin and high substance P and high catecholamines and all these things that we've written about extensively, they correlate with other things such as post-traumatic stress disorder or even below the actual diagnostic criteria of PTSD, things that some researchers have called distressing life events, right? Some people talk about ACEs, various childhood experiences and the like, that these same kind of similar constellation of neurotransmitter abnormalities exist in all of these type of disorders that involve this sort of traumatic experience.
Yes. And again, how much of that's genetic, we don't know yet.
And it's also interesting, we had worked on a textbook chapter in Jerry Mullen from Johns Hopkins' book about fibromyalgia and the association with irritable bowel syndrome and other kind of gut problems where the dysfunction in the gut's nervous system, the enteric nervous system in IBS seems to mirror the dysfunction in the central nervous system in disorders like classic fibromyalgia. And in fact, many of the same neurotransmitters or neurochemicals are actually involved. So it's really not a surprise that something like irritable bowel syndrome has, in some cases, almost 80 to maybe even 100% comorbidity, depending on what you look at with fibromyalgia.
Yeah, I mean, that's another great example. As we know, there are some patients with irritable bowel syndrome where you can trace it back to a food allergy or a chemical sensitivity or something else. But we know now there's a subset of patients with IBS who clearly it's a central sensitization disorder, very similar to fibromyalgia, and there's a lot of overlap between the two.
Right. What are some of your thoughts on why women seem to be much more susceptible to this? If they undergo that kind of upbringing with a lot of trauma and maybe even frank abuse, and they also tend to have other characteristics, right? They tend to be the meticulous overachievers, the sort of the kind of worry warts a little bit, and as adults they tend to be the uber caretakers, right? They're really worried about everybody around them and taking care of everybody around them, that something bad is going to happen to someone around them. So they tend to be wired, if you will, to use that term, in a certain way, right? They have a certain sort of constitution as a person. So I see those commonalities as well, and there's certainly outliers to this, but it's pretty consistent. But you see males who've been in similar bad situations in their upbringing, and they don't go on to develop classic fibromyalgia and IBS and things like that nearly like women do. They're affected by it, but I find that they develop more irritability, easy to anger, lashing out with maybe even extreme violence and things like that. But they seem to process things differently than the female brain. And I know that may not be politically correct these days, but it seems that there are differences between the male and the female brain and nervous system and stress response, and it reacts differently to different sets of stressors. What do you think about that?
Yeah, it's very, very interesting. I mean, the bottom line is we just don't know, but
right.
certainly men and women have physical differences that we know about, and it would not be surprising that their nervous systems are wired differently. I mean, the best evidence for this is in the post-traumatic stress disorder literature. And if we start looking at, soldiers that are coming back from battle, there's so many more females now in the military than there used to be in our generation.
Yes.
And as they start to study them, as we study soldiers, we're starting to see that, again, when really, really bad things happen in war to men, they internalize it. They are more likely to act it out against other people and commit violent acts towards others, whereas females internalize it, but they're more likely to do something to hurt themselves than somebody else.
Right.
They develop more somatic symptoms. We just don't know why. And it's not a matter of being politically correct. It's just science.
Right, exactly.
The data show us that females, when they're subjected to terrible amounts of stress, react differently than men.
Right.
What that's all about, who knows? And
some would say, even though both of them neither are healthy, and they end up in dysfunction, I would think that given the choice, at least from a societal perspective, the females are handling it better than the males.
Yeah, but who knows? I mean, I think as we study more and more veterans, one of the sad things of this of Iraq and Afghanistan is we've got many, many young people coming back with all these post-traumatic stress disorders. It'd be interesting to see how many of them develop fibromyalgia-type symptoms on the male side.
Right. Yeah, it is sort of an unfortunate laboratory of convenience, as they say,
Right.
But let's go back to, we had originally, and to my knowledge at least, we were the first to come up with this concept of taking the person who comes in front of a clinician, a healthcare provider, and says, "Doc, I have fibromyalgia." Now, they may have come to that conclusion through a myriad of channels, right? It could be that they were diagnosed by their family physician. It could be they were diagnosed by a rheumatologist at a center of excellence somewhere. It could be that their neighbor told them they had fibromyalgia. It could be they went on WebMD, and figured out they think they have fibromyalgia. But they come in and they say, "I have fibromyalgia." So that presents a challenge to the average healthcare provider, particularly to the conventional one who's got like 6 minutes to deal with this very complex patient, So we sort of divided the possibilities up. We sort of made a sort of decision tree, or an algorithm, if you will, that the clinician could help frame this up and work through this. And the two main buckets, as we call them, in our little diagram in some of our publications, and I used a modified format of that in the book, the Fibro-Fix, that they either have it or they don't. And when we say by have it or don't, we mean this true classic fibromyalgia. We don't mean they have something wrong with them or they don't. We're not trying to minimize that these patients have something wrong with them. It's just a matter of what is it. One side is they have classic fibromyalgia, and we're looking for certain, clues, like they have pain all over the body, up, above the waist, below the waist, right side, left side, everywhere. It's non-discriminating. It's achiness and pain everywhere. But they also have these other things we were talking about, IBS, depression, anxiety, unrefreshed sleep. At least they have some of that stuff going on. And then there's other people who, for some reason, they may have pain, they may have fatigue, they may have some vague gut problems, but they don't seem to meet that criteria. And we had called those people, we classified them as pseudofibromyalgia. And pseudo, of course, means false. So we were criticized a little bit in the literature for that because some people interpreted that we were trying to create a new diagnostic label or category of pseudofibromyalgia. We never were. Maybe we didn't explain it well enough, but we were trying to get the clinician just to think, okay, this might be a false label or a false classification of fibromyalgia. So now we have to go find out what it really is. And then we came up with 3 what we thought were the most common buckets that someone might be in that got them to that pseudofibromyalgia place, or a diagnosis of fibromyalgia when it was not exactly accurate. And do you want to talk a little bit about that partition and then maybe those 3 different buckets down in that pseudo category?
Yeah, sure. This has evolved over the years, right? I think now we can say bluntly, there are patients who have this thing we call fibromyalgia or central sensitization syndrome, and there are many who don't. And so I wouldn't call it pseudofibromyalgia. I'd call it a misdiagnosis.
Yes, of course. Yeah.
Let's call it what it is, right? So there are people who are diagnosed correctly, and there are people who are misdiagnosed.
Correct.
And of the ones who are misdiagnosed, we've kind of saw a pattern there, right? And so in a lot of things in healthcare, we look for subsets, right? We're looking for back pain is a great example. We can't treat all people with back pain the same way.
Of course, right.
But there's sort of 3 or 4 subsets, and we can match treatment approaches to these subsets. And so you and I came up with 3 big subsets, right, of the misdiagnosed cases. So if the people have been told they have fibromyalgia and don't, a lot of them have musculoskeletal problems.
Right.
Right? Trigger points would be a good example.
So myofascial pain syndrome, or even other a grouping or a constellation of musculoskeletal problems. They may have some issue down in their back pelvic area. They have facet syndrome. They have some disc lesions. They have some sort of articular dysfunction, myofascial problems down in that area of the body. But then they might also have some other, cervical spine issues or shoulder trigger points or, a multitude of things. And to someone who's not really paying attention to the patient, they just know they think they hurt all over, right? Because they hurt here, they hurt there, they hurt there. But to a clinician who doesn't take the time and ferret through all of that and do a good exam, do a good history, they may just hear Mary Jones say, well, I hurt here, I hurt here, I hurt there. And they think, oh, they hurt all over, and they're fatigued. Oh, they must have fibromyalgia because they're a woman. Right. Well,
so this comes down to what's your definition of widespread pain.
Right.
And so to a lot of people in the primary care world, including nurse practitioners, physician's assistants, primary care docs, it's not that they don't understand the human body, but they don't understand the musculoskeletal system very well.
Right.
So if a patient has neck pain, low back pain, and shoulder pain, they interpret that as widespread pain, fibromyalgia.
Right.
And unfortunately, that happens way too much. And that's one of our buckets, right?
Right.
People who have localized musculoskeletal problems that get lumped together and get misdiagnosed as fibromyalgia.
Right. And by the way, they might have some other condition that makes them fatigued. Let's say they're anemic or they have some other, metabolic issue that we'll talk about. So sometimes patients have, they have the right to more than one disorder at any given time, right? So sometimes they have a couple of things that all together collectively produce a constellation of symptoms that may make a clinician say, oh, you have fibromyalgia, when in reality, different symptoms are caused by different individual problems. And if you identified each of those and treated them appropriately, they would resolve.
Yeah. Well, the reason I mentioned the musculoskeletal misdiagnoses first is because I think that represents the biggest category of misdiagnosis.
Yeah, I think it's certainly up there. It's one of what I call my top three masqueraders of fibromyalgia, right? And I don't mean the three buckets. I mean the three specific conditions which I think masquerade as fibromyalgia the most effective and get people in misdiagnosis the most frequently.
And that it just sort of begs the question: why is there so much misdiagnosis here? And I think that gets back to the way that medical physicians and nurses and physician's assistants are trained. They're trained in internal medicine. They're not trained in musculoskeletal diagnosis. And I think that's where the biggest problem comes in.
Unless they're specialists in that kind of field, physiatrists or, orthopedics. But even then, they're so subspecialized in many cases, they're having a hard time putting the whole picture together.
Yeah, but the patient with fibromyalgia-like symptoms, who are they going to see first? They're most likely the first contact provider is going to be somebody at the primary care level.
Exactly.
And that's where I think things go wrong a lot of times.
Right. Okay, so we have the musculoskeletal bucket. What's another bucket in that false diagnosis?
Well, I hate to say this, but there can be true misdiagnosis where somebody has a really serious medical problem.
Right.
Like cancer, multiple sclerosis, really serious disorders that cause widespread pain and fatigue. And shame on the primary care person who's seeing them, where they don't take this person seriously.
Right. And
they completely diagnose something that's serious. And unfortunately, that's happening more than we'd like to realize.
I know you've probably had similar experience. So I've had people come in and say they're there for fibromyalgia. And I say, well, why do you think you have fibromyalgia? Because, I don't believe it until I prove it to myself, but I don't necessarily think they're wrong, right? Because patients come in and sometimes they're wrong about their diagnosis. And, a lot of times they're right, especially with all the information out there these days. But when I ask them how they arrived at that conclusion, they may say that their primary care doctor had told them that they had it, or their internal medicine doctor, or even I've had it, unfortunately, several times where they were actually seen by a rheumatologist. They were, autoimmune disorders were ruled out. They did all the, serology and all for inflammatory autoimmune conditions and the like, but they didn't really have a comprehensive medical workup. Barely anybody put a hand on them. They didn't examine them. They did not do a thorough history. And when I looked through the laboratory work that was done, they had not had all of these sort of medical conditions ruled out that should have been ruled out before they were ever rendered a diagnosis of fibromyalgia. And that is part of the official diagnostic criteria. That's one of the main tenets of it, that it has to be a condition that's not explained by some other medical problem, correct?
That's correct. And, therein lies part of the problem. I think that the classic case gone wrong is, and again, not to be politically incorrect, but if we have a male doctor with a female patient that tends to be a little bit emotional and can't really put her finger on where her symptoms are, that's a bad scenario.
Yeah.
It's a bad scenario where the doctor doesn't really listen to the patient's symptoms and may not do a full medical workup. And unfortunately, I like to call it the F word, fibromyalgia.
Yeah.
It's very easy to throw the F word at a patient and dismiss them.
Right.
Especially if you're busy and there isn't something glaring jumping out at you. But this is unfortunately a big problem in medicine. Yeah. Misdiagnosis of fibromyalgia when there's an underlying medical problem.
Well, I know there was a famous study by one of the rheumatology, giants in fibromyalgia research, Fitzcharles, a while back. So it used the previous ACR, the American College of Rheumatology criteria for the diagnosis of fibromyalgia as its basis, but it looked at patients who were diagnosed by that original criteria with fibromyalgia by either their primary care physician or even a rheumatologist. And then they took those people who were diagnosed and they had them seen by a panel of fibromyalgia experts who were rheumatologists. And what they concluded was that only about 1/3, 33% of them, were diagnosed correctly according to the diagnostic criteria, and that therefore 2/3 of them were misdiagnosed. And that was misdiagnosed by a physician, and in many cases a rheumatologist who's supposed to be a specialist. So you can imagine how much worse that is when people are diagnosing themselves by, with web resources or some other kind of healthcare practitioner who may even not be as highly trained, be making that call or that diagnosis.
And to take that one step further, so if 2/3 of them didn't meet the criteria, what was the cause of their widespread pain and fatigue?
Right.
Okay?
Yeah.
They had something wrong with them.
They had something wrong with them. They weren't all making it up, right? And,
That's right.
And you go back to that scenario, and it's changed, I think, a lot. I think there's a much more of an awareness and acceptance of this of fibromyalgia as a real medical entity, much more so than even 10 years ago, and certainly more than 20 years ago. We've had shifts in the medical provider demographics where there's a lot more women, providers and physicians. So I don't think you see that scenario play out as much as you used to, but you still do see it play out where you have the male physician, the female patient. It's like a disconnect, right? And the old sort of stereotypes happen. Oh, it's hysteria, right? And we even see that in the nomenclature of different diseases, like, the hysterectomy, for instance. Or I remember, I think you pointed this out to me after doing a literature search in preparing one of our papers or one of your presentations, that in the 1950s, they were describing what we would probably describe fibromyalgia now with the term psychogenic rheumatism, right? That it was all in your mind and that it was rheumatic. It was a rheumatic disorder. It was a joint disorder. It was made up. It was like wrong on so many counts, you can't even count them up, I guess. But it's interesting. It showed a mindset, right?
Right. And I think that if we don't put that label on people anymore, now it's easy to put the fibromyalgia label on people.
Yeah, it is.
Yeah. And one of the things that also is getting really is a problem in our society is that medicine has become so efficient or inefficient, if you will, and with managed care and insurance companies dictating care, primary care physicians are not routinely, for example, doing some blood tests and doing some at least minimal screening testing to rule out some of these conditions. And so it's just basically going by a case history with the patient.
Right. And if they're a woman, especially a middle-aged woman, has had a lot of stress, she seems to have a lot of pain all over, seems to be tired and run down, especially if there's some vague gut symptoms, there's a little bit of blue mood or depression or anxiety, boom, you're going to get that diagnosis.
Yeah, well, we just went through this with a friend of mine's wife. It turns out she has multiple sclerosis. Right. It took 3 years of her being told she had fibromyalgia before she really started showing some overt symptoms. Right. But in the early stages, she just felt tired all the time, having weird sensations in different parts of her body. Right. And her primary care doctor was not taking her seriously. Right. It wasn't until she started stumbling and showing weakness. Right.
Overt neurological signs of MS. Yeah.
Yeah. But in retrospect, she said, I've had this was all multiple sclerosis as I look back.
Right. And unfortunately, many of these patients, either because the doctor doesn't want to deal with them anymore or because they think it's the right thing to do, sometimes a combination of the two, they get put on psych meds. They get put on, even the drugs, the old standard go-to drug for a long time was amitriptyline, which of course is a repurposed antidepressant medication and was used a lot to try to improve the sleep, to get more refreshed, restorative sleep, and it seemed to help their pain over time. And then it became used a lot just for all kinds of different sort of pain syndromes, and it sort of became repurposed for that. But then you had the advent of these newer classes of antidepressants, like I review them in the book, like the SNRIs or SSNRIs, some people call them, the selective serotonin norepinephrine reuptake inhibitors, and even the alpha-2 delta ligands, which are repurposed anti-seizure or epileptic drugs. And these things basically dumb down the nervous system, and they can help with sleep, they can help with pain, they can help with mood to some degree, at least the SSNRIs, but they're certainly not going to help a person that does not have a centralized problem, that does not have, in classic fibromyalgia, they have a chance to help, at least some, but even in those patients with true classic fibromyalgia, the percentage of responders who get any kind of significant benefit from those type of agents looks to be somewhere around 25% or less, actually. So that's not great. And those who do get benefit, the benefit tends to wear off after several months, and they end up sort of back at the same level of pain and dysfunction they had, but now they're on these medications and they have potential side effects from them. But what about all those patients who never had fibromyalgia to begin with? They had a thyroid condition. They had a mitochondrial, metabolic energy production problem at the core of their biochemistry. They just weren't making enough energy. Or they had MS, or they had a musculoskeletal problem, but they were told they had fibromyalgia and they get put on these psych meds. I mean, that's not a good scenario. There's only downside. There's no upside to those people.
Well, what's worse than that? What if that person does have, and I've seen this, really serious problems, like I had a lady with liver cancer, right? She has liver cancer and she's being told that she has fibromyalgia and being put on psych meds.
Right.
Now, the psych meds helped her sleep a little bit at night, but her cancer is getting worse.
Right.
Right. And she's not getting diagnosed properly.
Right.
And the really sad thing about all of this is that all the doctor has to do is palpate the patient to feel, are they really tender all over? And it sounds crazy, but isn't it true that in America, if you go see a primary care physician, they will not literally even touch you?
Generally not. And if anyone does touch you, it's usually the medical assistant or, if you're lucky, a PA or nurse, but usually it's a medical assistant doing your vitals, and that's about all you get touched. They're standing on the other side of a desk or walking in the room, looking at their iPad or whatever. They're not really touching you. And
so here we have a disorder where the hallmark symptom is widespread tenderness.
Right.
Right? Hyperalgesia, allodynia, a substantially decreased threshold to stimulus. And all the doctor has to do, or the nurse or the physician's assistant, all they have to do is just palpate the patient a little bit to determine whether or not they're really sensitive. And they don't even do that.
No. I don't think they're really comfortable. And this is an acknowledged deficiency in modern medical education, that physicians no longer feel comfortable putting their hands on patients. They're not very adept at good old nuts and bolts physical exam. They don't know how to use stethoscopes very well. They're so used to MRI scanners, nerve conduction studies, high-tech medicine. That's great stuff. But, sometimes you just need to go back to the basics. And here's an example, because how many times have you been in the clinic and a patient says, I have fibromyalgia, and we ask them, well, is the pain in your joints or more in the soft tissues or the muscles or, and they say, oh, it's in the joint. So that's a cue to us. Maybe it's something else, right? And we're off on another tangent. But let's say they say, no, I think it's in my muscles and my soft tissues. Well, do you hurt everywhere? Above the waist, below the waist, both sides? Yeah, I do. And then you do an exam. And even if you just sort of squeeze big muscle groups or put some pressure, not even precisely measured pressure like the old criteria with the algometer and all, just squeezing muscles, pushing on muscles, and you'll find out there's certain areas that they go, it really hurts. But then there are whole other areas, large muscles of the body that you push on, you squeeze on, they're fine. It's just pressure. That's not global pain. That's not classic fibromyalgia. They likely have a localized or multiple localized musculoskeletal issues where they hurt. And if they had classic fibromyalgia, it would not have discriminated to different parts of the body if it's coming centrally from the brain, correct?
Correct. I mean, you're actually describing the simplest way to put the people into two buckets, right?
Right.
Either you have classic fibromyalgia or you don't. All you have to do is just do what you just said.
Right.
Feel a couple muscles, and they hurt in certain areas, they don't hurt in others. And then on top of that, how many times have you had this happen to you? When you find one of those sore areas and start to put a little pressure on it, the person says, oh, that hurts, but it kind of feels good at the same time.
Right.
And that's a patient that's come in with a fibromyalgia diagnosis? I don't think so.
No.
And we see that routinely.
Right.
Yeah.
Or you go where they say it hurts and you palpate and they have the classic nodularity, taut bands, and you hold it longer and they have the classic referred pain pattern of a specific trigger point in that area of the body.
Yeah, I often tell some massage therapists that if you have a patient, a client, if you will,
right.
that comes to you for a massage and they have a fibromyalgia diagnosis, but they like deep pressure massage, they don't have fibromyalgia.
No.
They have something else.
Right.
Because
unfortunately, those patients with true classic fibromyalgia and this global pain that's emanating from the central nervous system, You can mash on the muscles, you can pull on them, tug on them, electrify them, ultrasound them, do anything you want to them. You're fundamentally not changing the scenario. The peripheral treatments can't treat a central disorder. Peripheral treatments treat a peripheral disorder. And in many cases, you're just sort of torturing the person. You're causing pain, but you're not creating any benefit along the way.
Yeah, the only thing that I would say about that is that patients with the classic fibromyalgia, central sensitization type of syndrome,
right,
do well with desensitization type treatments.
Right.
So that type of patient, if they go to a massage therapist who does very, very light massage, they're in a room with dark lights, aromatherapy, nice music.
Right.
They have all this low-level stimulation. It can actually be therapeutic for them.
Sure, and also someone who's paying attention to them, nurturing them, touching them. They're actually spending some time on themselves, right? They're finally calming down. There's a tremendous amount of therapeutic benefit in those aspects of that patient or client encounter, correct?
Right. Yeah. So when I see a patient as a chiropractor that has more of these classic fibromyalgia symptoms, I like to get them to a massage therapist that does very light work.
Right.
And I like to get them involved with other therapies that get them engaged and moving again, like Tai Chi and yoga are good for them.
Right.
I'd much rather see the patient go through these, standard medical treatments than being put on a whole bunch of drugs and, be told to live with it.
Right. So, you're getting back to getting the body moving again and motion and things that are calming at the same time. So we're not talking about exertional, vigorous exercise. We're talking about more slow range of motion, stretching, things like Tai Chi and Qigong and yoga. And the Fibro-Fix books gives exact sort of protocols you can go through to start attaining motion again in a very safe way. But I think regaining that mobility and that motion is really critical as part of their recovery. But many of these patients are deathly afraid of anything that they perceive as exercise, right? Because every time they've tried to go out and do something and exert themselves, well, they get trashed and they may be in bed for 2 days.
Right. And so that's part of the educational process with the classic fibromyalgia patient, is explaining to them that a little bit goes a long way.
Right.
Yeah. One of the things we haven't discussed here is that third bucket of the functional type of fibromyalgia patient. I think we should discuss that as well.
Yeah. That functional side, which I spend a lot of time on in the book, and we've written about it extensively, is particularly tricky because these are actually metabolic or internal disorders that are not overt diseases, right? So they often fly under the radar. They're not appreciated. They're undetected by conventional physicians or conventional providers that have been trained to look for disease. It may be more appreciated by integrative functional medicine doctors, even clinical nutritionists and other people who really understand that side of it. But things like how the cells make energy in the mitochondria, how you're detoxing, are you assuming some sort of cumulative toxic load that is sort of putting stress on your metabolism, including mitochondrial, sort of poisoning the mitochondria, if you will. Also things like underappreciated or underdiagnosed, not overt hypothyroidism, but thyroid insufficiency, right? It's not really performing to the peak. Your lab works within the range, but it's in the low end of the range, but you just feel like you got hit by a truck. Your temperatures are low. A lot of those people, we treat their thyroid and the lights come back on, and all of a sudden their fibromyalgia is gone, their muscle pain's gone, their fatigue's gone, they can think straight, their bowels start moving with normal peristalsis, and everything's fine, but yet they had actually been screened for a thyroid disorder by their family physician. So that's that other bucket, this metabolic functional bucket that we call it.
Right. And I think as we talked about before, people can have overlaps of all of these.
Right.
Right.
Exactly.
And that they're not mutually exclusive silos where you have this functional problem with your mitochondria not producing energy, or you have a muscular problem with your muscles.
Right.
You can have both.
Right. Exactly.
And in fact, that's probably more the norm than the exception.
Right.
Right.
And that's, a lot of clinicians go wrong. The first thing they find that they think, yeah, this is it, and you got to keep looking, because sometimes it's a perfect storm that's ganging up on the patient, and it takes more to get them well. But the last thing I wanted to talk about in our available time is I know that you're very aware of all the literature on cognitive behavioral therapies, or CBT. So, there's a lot of stuff on mindful meditation and biofeedback. And so can you talk a little bit about some of those? What is cognitive behavioral therapy, and how does that fit into particularly the patient with true classic fibromyalgia?
Yeah, well, cognitive behavioral therapy is a psychological technique that typically psychologists will use with certain types of patients. And it's a technique that it's not Freudian psychology where you're going to come in and we're going to get into your deepest emotions. It's more functional and pragmatic. It's an approach where psychologists will try to get patients to self-reflect about their own thinking.
Right.
And a lot of these fibromyalgia patients tend to display certain characteristics, for example, catastrophizing, making a mountain out of a molehill, or being sort of obsessed about their symptoms. And so if a practitioner can get the patient to be mindful that they're doing this, they can consciously change that without having to go through extensive therapy and psychoanalysis.
Right.
And it's a helpful technique, and it's been shown in a lot of research studies to be very, very helpful for fibromyalgia patients.
What are some of the, some of the things that are thought of as under the umbrella of CBT? I mentioned biofeedback. I mentioned mindful meditation. What are some things you consider in that domain?
Well, I think those are two of the biggest ones. I mean, mindfulness meditation classes can be taught in groups. Very, very popular. There's some evidence to show that that's actually helpful for fibromyalgia patients.
Right.
And any kind of stress reduction classes where patients learn how to think about their own thinking.
Right. So in the book, I talk a lot about, guided imagery, progressive relaxation, but you got to find something that resonates with that patient. It could be more time in recreation, like prayer, gardening, something that's not, very physically stressing, that soothes them. Yoga, even if it's light, the right kind of variation of yoga. I know there's some in-office, or now there's even at-home, sort of on your laptop, variations of things like heart rate variability training and the like. So there's everything from high-tech to low-tech when it comes to some of these techniques. But I think that that's a very important component for these patients that actually have classic fibromyalgia.
Yes, I agree. Even things like listening to classical music, or being involved with a hobby or an art that you enjoy. People have to get their mind off of their pain. What we find is that in the patients with these central sensitization syndromes, they're just too focused on their pain all the time.
Right.
And they need to learn how to focus on other things and recognize that having a little bit of pain is part of life. Everybody has a little bit of pain.
Right. And that's understandable. I can imagine them saying, oh, well, you don't live with what I live with. So we're not trying to minimize it. We're just saying that, we're trying, as you try to get it better, part of it is also to reframe your thinking about your symptoms and your pain and your recovery, because that's classic, chronic disease sort of mentality sets in, and catastrophizing and all this, particularly in this disorder. So it's just part of the recovery process, and it's not meant to mean that people are making this all up, or they're making it, more than it may be intentionally. It's part of the healing process. As far as counseling goes, I've been interested in looking at some of this new literature on instead of let's say you had trauma or you had abuse. Instead of sort of going back and reliving it to sort of process it out, if you will, that may actually be damaging in many of these patients. That there's a new approach called forgiveness therapy, where they're actually trying to have the person come up to some level of acceptance and, if possible, forgiveness, and moving on, rather than reliving it all. Sometimes it was a family member, maybe a parent who abused a child, maybe as an adult that victim, if you will, the person with classic fibromyalgia, may come to understand that parent, when they were a child, were abused in the same way, and it's sort of this cyclic thing. So, that there was more underlying it than you would think, and oftentimes that elderly parent maybe is different now. They've calmed down, they have a different personality. You can sort of make amends, you can sort of resolve things. Sometimes that's not possible. They're deceased, or they've never changed their ways, but it's up to that person to sort of internally forgive, accept and move on. That's sort of a new way of dealing with this, and it's kind of an interesting concept.
Yeah, I think it is. It's very interesting. And again, I don't think this is when patients have these classic fibromyalgia symptoms, if they are going to work with somebody in some form of psychotherapy, they really should be with somebody who's trained and knows what they're doing.
Absolutely.
Right.
Yes.
Otherwise, that they're going to spin the wheels there as well.
I find when I'm trying to find therapists for patients of mine with classic fibromyalgia that I'll at least try to contact that therapist and find out how much they know about, even if not fibromyalgia specifically, do they have a basic understanding of concepts like post-traumatic stress disorder and, what the actual manifestations of that are in the nervous system and in the stress response? Because that can be very helpful. Even if I say, well, why don't you treat them almost as if you would be treating a post-traumatic stress disorder patient? Because I think that there's a lot of linkage there. And there's benefit in the approach no matter which patient profile you're dealing with. So that being said, thank you for taking the time out of your busy schedule. You're, as I said, a wealth of knowledge. And is there any place our listeners can go to learn more about you and your research and your work?
Not really. I work at the University of Pittsburgh, so yeah.
Is there a bio for you at University of Pittsburgh, or
probably somewhere? I mean, I just do research now, so I'm not out in the public's eye. I'm just doing my stuff quietly in the ivory tower.
Using public funds, though, are you?
Yes, I am.
All right, good. Well, I know that you are putting them to good use. So, thank you, Dr. Schneider. I really appreciate it.
Okay, thank you.